Thank you everyone for joining and welcome to the Diagnostics and Primary Care webinar. I'm Zara Gross and I'm the Early Diagnosis Lead in South East London Cancer Alliance, and I'm joined by our two presenters, and we've got Dr. Anthony Cunliffe. Anthony is Joint Clinical Chair of South East London Cancer Alliance. He's also Joint National Lead Macmillan GP Advisor and Macmillan GP Advisor in London. And we've got Dr. Saoirse Dolly, who's Medical Oncologist and RDC Consultant at Guy's and St Thomas's RDC. So I'm just going to go through a couple of housekeeping rules and also touch upon the evaluation form. So just to let you all know, you are on mute and your cameras are off by default, just to ensure that we've got clear communications throughout the webinar. If you've got any questions, please click the Q&A button on the bottom of your window. If you'd like to discuss anything with audio or video, then please let us know when you're asking your question. We'll cover questions either during the presentation or after the speaker has finished. And if you've got any technical issues, then please let us know via the Q&A button. And finally, the presentation will be recorded. A certificate of attendance will be given to all attendees on completion of the online evaluation form, and the link to the evaluation form will be available after the webinar, either via Zoom and via the Eventbrite email that will be sent to all of you after the webinar. So I am going to hand over to Anthony, who is going to take us through cancer diagnostics in primary care.
Thanks, Sarah. Hi everyone, thanks for joining today. Yeah, so we're going to talk very much about diagnostics today with a focus on the rapid diagnostic centre that we have in South East London as well. So I'm going to talk through the first few slides, really focusing on the diagnostics that we have available, perhaps looking at ways we can use those diagnostics to diagnose cancer in ways where maybe we weren't necessarily aware of. But also I really want, I know we sometimes have challenges in accessing diagnostics, but I'd really like the thrust of kind of my slides to be about how important we are as primary care physicians in diagnosing cancer, and hopefully you might all go away feeling a little bit empowered about how we're the key really to driving early diagnosis. And then I'll hand over to Saoirse, who will talk about the Rapid Diagnostic Centre. We aren't going to speak for the whole of the time today because we really want to make sure that there's time for questions, and I was presuming, and hopefully I'll be right, that there will be lots of questions from you guys on diagnostics. Please feel free to ask any questions. You can put them in the chat at any time. You don't need to wait till we have a gap for questions. If you put them in the chat at any time, Zara will be keeping an eye on the chat, and then we can address questions as we have gaps in the presentation. So primary care and cancer, really. So as I say, primary care has an essential role to play in the earlier diagnosis of cancer. GPs and the whole primary care teams, really, in my opinion, are the key to achieving the significant shift in the early stage diagnosis that we need, that the government has challenged us to achieve as cancer alliances. Most people, it's not always the case, of course, some people present to A&E first, but most people do present first to their GP on their route to diagnosis. That will include people who present, have investigations, and then are referred on an urgent suspected cancer referral pathway. It'll be people who present with perhaps vaguer symptoms that go on a normal managed referral pathway and end up having a diagnosis of cancer. It may be people who see the GP and are undergoing investigations but subsequently present as an emergency. And then it's also people who perhaps present to us and then are seen by the rapid diagnostic centres, which we'll talk about later. We know that a full-time GP will only see around 8 or 9 new cancer diagnoses each year. I'm sure that's a statistic many of you have heard before, but every day we have multiple people presenting with symptoms that could present cancer, present a patient having an underlying undiagnosed cancer. So it's a challenge for us as GPs to identify those people that need referral or just those people that need further investigation. So access to diagnostics for GPs can vary significantly. We know that across London, across the UK, it varies very significantly. But even across South East London, we see variation in the tests that we can access directly as GPs. And we've seen this inequity widened, unfortunately, through the COVID pandemic as well, with even more limitations on some of the tests that perhaps we sometimes take for granted because of the inability to maintain cold pathways, or the challenge of maintaining cold pathways. Many of the easy to diagnose diagnostic tests have perhaps more of a role to play in cancer diagnosis than we might realise, and we'll focus on that a little bit today in the upcoming slides. Having a better understanding of the importance of some of these tests can be quite empowering as a GP, both in giving perhaps you confidence in making a referral, or confidence in being reassured that perhaps there isn't anything to be concerned about. It is important to understand the pitfalls of some of the tests, particularly around false negatives, and we'll talk specifically around the risks of false negatives. And it's also important to understand why some tests are vital before we make a referral. And I guess the reason I flagged that is because, you know, for a lot of the two-week rule referral pathways, we do need to make sure that people have had certain tests done, and that if they've not had them done, it may cause delays. But also, because we're going to be talking about the Rapid Diagnostic Centre, by definition, it has a set of screening, in inverted commas, tests that people need to have done before they get a referral made. And that isn't just about having all the information that they might need in the centre when they see a patient. It's actually because a lot of those tests might actually flag up a two-week referral pathway that that patient would need to go down, rather than going down the Rapid Diagnostic Centre route. So I'm going to talk a little bit about some blood tests. Now, I've just realised that I've got this slide here now, and I'd made myself lots of presenter notes at the bottom, which I can't now see, but hopefully I'll be able to manage anyway. And I wasn't going to go into the details of all the different nuanced referral pathways that are involved in the NICE guidelines, but really just to flag that maybe there are some simple tests that we can do that might augment the decisions that we're making about referral or not referral. And these are all from the NICE guidelines. So when the NICE guidelines were changed in 2015, they did become a lot more nuanced. They did become a lot more about collaborations of symptoms with collaborations of test results. And that's why it's important to be aware of how important a lot of these tests are, and at least know where we can then go and refer to find out the specific details that the NICE guidelines involve. So for upper and lower GI cancer, I'm sure we're all used to doing a hemoglobin to check for anemia as one of the things that might help us make a decision about whether we want to refer somebody for investigations or on a two-week referral or not. But over the last few years, and thrombocytosis will come up in quite a few of these cancer types now. So there was the last few years, there's been a lot of studies done on raised platelet counts and how important they can be in helping us diagnose cancer. And certainly both for upper GI and lower GI cancers, they're referred to as part of the LEGO cancer, so LEGO, LEGO C, so LEGO-C cancers, for which thrombocytosis or a raised platelet count can help us in deciding if we need to make a referral or not. So a raised platelet count, certainly a persistent raised platelet count, can be, along with other symptoms, of course, and other demographics, can help us make a decision about whether somebody might have an underlying GI cancer. Endometrial cancer is another one where the NICE guidelines brought in a couple of new blood tests as part of the criteria. And again, these blood tests are involved in a collection of symptoms rather than just being a referral criteria by itself. But certainly for endometrial cancer, both raised platelet counts and a raised glucose level, along with other symptoms, other collections of symptoms, are in the guidelines for referral for endometrial cancer. So what I'd really encourage everyone to do is, after this talk, really maybe use one of the really easy access referral guidelines we have, and I would suggest the Macmillan Rapid Referral Guidelines, and we could maybe send out the link to that. But if you Google Macmillan Cancer Referral Guidelines anyway, you should come up with the Rapid Referral Guidelines. And if you go in, you'll see what symptoms the raised platelet count and the raised glucose and the low hemoglobin go along with to meet the criteria for a referral for endometrial cancer. Lung cancer, certainly raised platelet count is one of the significant ones for lung cancer. And so when we have a cancer like lung cancer that's really hard to diagnose early, perhaps early on, especially in those people that might have chronic respiratory symptoms, that it's really hard to diagnose changes in those respiratory symptoms in a raised platelet count might raise our concern about potentially an underlying cancer. Bladder cancer, again, often we'll do a blood count with people who were suspecting a potential underlying cancer in, and a raised white cell count, again, along with other collections of symptoms, are in the NICE guidelines for referrals for bladder cancer. Obviously, hematological cancers, we very much rely on our full blood count, and I wouldn't go into all the details there because there are multiple full blood abnormalities that might raise a concern about hematological cancer. Although I might flag people to, there's a really great link on the new 2-week rule hematology forms, which actually is like confirmation from Zara that they are live now, a link on those forms to the specific full blood count abnormalities that would signify that somebody needs an urgent suspected cancer referral rather than just the routine hematology referral. And perhaps when we come to the end of my section, do you want to come in there, Zara?
Yeah, I was just going to say they're not live yet, but they're due to be live in the next couple of weeks, and we'll send out some targeted comms to all practices highlighting the updates. That's
great, thank you, Zara. Ovarian cancer, obviously most of us are aware of the CA125. Have a low threshold for doing this ovarian cancer is a very difficult cancer to diagnose at all, even harder to diagnose at an early stage. So consider doing a CA125, and I would really encourage, and I think NICE guidelines say either or I should say, but I would encourage simultaneous request of a ultrasound when you're doing a CA125 for suspected ovarian cancer, partly because that ultrasound may take a few weeks to happen. And even if you've got a normal CA125, I think it's around 19% of people still may have an underlying ovarian cancer. So having requested that ultrasound acts as that safety net that you've got that other investigation in place for those people with a normal CA125. Obviously, if the CA125 then comes up raised, you may want to supersede the ultrasound referral with a 2-week rule gynecology referral. The newly diagnosed type 2 diabetes, it comes in the new guidelines for pancreatic cancer as one of the criteria, again, along with a various other collection of symptoms in people above a certain age. And certainly myeloma, one of the hardest cancers to diagnose, one of the cancers that has the longest route to diagnosis and the most primary care attendances before diagnosis, because it's so hard to diagnose. But ironically, all the tests that we use to diagnose myeloma, these initial tests, we have easy access to in primary care. So again, maybe just a low threshold for doing these tests. I mean, NICE says start with the full blood count, ESR and calcium, and then move on to electrophoresis and BJP if there's any abnormalities there. Obviously, we don't see many myelomas, but it is hard to diagnose early. Chest X-ray, first line test for lung cancer. I'd really like to encourage everyone to have a very low threshold for doing chest X-rays. We should probably be doing many more than we do, and not only for respiratory symptoms, but certainly it should be part of the first line investigations for anybody with weight loss. Even if it's a weight loss as a single symptom, we should be doing a chest X-ray in everyone. Chest X-rays are probably not my role to say, but the cheapest chips, and it's a very low dose of radiology, so we should be doing lots more chest X-rays. However, remember, and this is one of those false negatives that we have to be really aware of, around 23% of people who are subsequently diagnosed with lung cancer will have had a normally reported chest X-ray. So just empower yourself that if you have a normal chest X-ray, but you have ongoing concerns regarding lung cancer, do a 2-week referral anyway, and just explain why you're doing that in the free text. And we've seen a very, very significant reduction in requests for chest X-rays due to COVID for multiple reasons, and for a lot of obvious reasons, of the overlap with symptoms, for people not wanting to necessarily go into a health setting to get a chest X-ray, for restricted access to chest X-rays for us in primary care. But it is really vital now that we get back to pre-pandemic levels, because the 2-week rule route for lung cancer is still the one that's lagging significantly behind pre-pandemic levels. And most of the other pathways are now up to 85, 90, even some of them up to over 100% of pre-pandemic referral levels. But lung cancer is still around 60%, so we've got a long way to go there. Please be clear on the information request form. If you're doing a chest X-ray for suspicious lung cancer, write that specifically on the X-ray so you can get a better quality of report. Most chest X-rays are walk-in, so please do safety net. Just because we give somebody a form, they won't necessarily go and get that chest X-ray done. So please make sure you safety net to make sure the X-ray has been done. And after a suspicious X-ray, most people should be triaged straight to test. But it is a direct access diagnostic, so the responsibility is down to us to make sure people have had the subsequent actions that are needed. Ultrasound, really useful in many ways, but does have limitations that we need to be aware of. Be aware of how long it takes for us to get a test. If we're doing an ultrasound and we're suspicious of a cancer, really be confident if you're going to get that ultrasound within 2 weeks, which is what NICE says, and safety net so you can make sure that somebody's had the ultrasound and that we've got the result, because if we request it directly, like all direct access diagnostics, the responsibility aligns with the requesting doctor to follow things up. It comes into NG12 so the NICE guidelines for endometrial cancer, liver cancer, soft tissue sarcoma, testicular cancer, ovarian cancer, bladder cancer, and there's one I can't see there, gallbladder cancer, not bladder cancer. Now, again, this won't be necessarily the first line for all these cancers. For some it is, for some like liver, if you're suspicious of liver cancer and you can get an ultrasound within 2 weeks on a timed pathway, that's the first line. For many of these, it won't be the first line. It'll either be if you can guarantee that you can get one within 2 weeks, or it will be for people with slightly lower risk, but not the first red flag symptoms for cancer. It'll be people for slightly lower risk, which for the first time in 2015 with the NICE guidelines, we saw guidelines for urgent and non-urgent investigations. It's suggested as a test for pancreatic cancer in people with specific symptoms, people over 60 with weight loss and some of the symptoms. However, at least 10% of ultrasounds will be normal in people with a pancreatic cancer. So really, we would generally encourage, if you can get a CT, get a CT, or if you are concerned about pancreatic cancer, just do a 2-week referral. Don't rely on the ultrasound. This perhaps is a little bit controversial, but consider where the ultrasound is happening. I know some of us may be challenged by some reports that come from some of our AQP ultrasound providers. I'm sure some are great, but some are perhaps not so reliable. So just be considered that if you really are suspicious of cancer, perhaps request a ultrasound. And as I say, it is a direct access test, so it is our responsibility to follow up and safety net. I'm almost finished now. So endoscopy. NICE guidelines suggest direct access upper GI endoscopy for multiple different situations, for both urgent and non-urgent. So it's really important that we know what we have access to. I think most of us in South East London, if not all of us, don't actually have access to an urgent GI, upper GI endoscopy, so within 2 weeks. So the only option we have is to do a 2-week referral if we've got a high suspicion of upper GI cancer. There are lots of non-urgent criteria that are involved in the NICE guidelines, and it's really useful to have a reflect on them using one of the easy access tools that I mentioned, like the rapid referral guidelines from Macmillan. That suggests within 6 weeks, and most of us will be able to have direct access endoscopy within 6 weeks. So it's important that we know when to request those. Interesting, and this will ask us about CTs as well. If we could get upper GI endoscopy within 6 weeks, would we be happy to use that more rather than a 2-week referral route? The reason NICE included this was because for ruling out an upper GI cancer, endoscopy has such a high specificity and sensitivity that it is, as good as doing a 2-week referral. But obviously, sometimes it comes down to a GP confidence in using these direct access and then being comfortable that we don't need to take any further action and that we have ruled out a cancer. It'll be interesting in some of the discussions if we can bring in whether GPs would use these if it was readily available. For lower GI, all the 2-week rule guidelines are not direct access. We do use FIT now, and we'll come on to FIT a little bit later, but so people might have lots of questions about FIT, but all the NICE guidelines, either with or without a positive FIT, are for 2-week referral, not direct access endoscopy. Although in South East London, most of us have telephone triage clinics for lower GI endoscopy anyway. CT MRI, so NICE guidelines just suggest direct access CT abdomen for pancreatic cancer in certain situations and direct access MRI for suspected brain cancer. Most of the time, most of us don't have this direct access, not in line with cancer waiting times, and by that I mean not within 2 weeks and on a monitored patient tracking list. So for most of us, the only option is to do a 2-week referral anyway. But again, it might be useful for us to have a discussion of whether if we had the confidence that we could get these tests done within 2 weeks, would we make more use of them? And it's important because NICE says we should have access to these. We don't have access to a lot of them. And if we want to use commissioning levers to try and get access, then the stronger the primary care voice, then the better. Equally about CT thorax, there was just a big study done by the UK Lung Cancer Council that suggests that GPs should have direct access to CT thorax when we're concerned, perhaps in those people that have had a normal chest X-ray and may have ongoing concern. We generally don't have access to this and can only do a 2-week referral, but would we use this if it was available? I think this is probably my last slide now. So FIT, the fecal immunochemical test now, first line as triage for low risk suspected colorectal cancer, and since COVID, we've been using it as a triage tool for high risk colorectal cancer as well. NICE did have guidelines for FIT back in 2015 when it was introduced. Essentially, it said for anybody who didn't meet the other criteria that you were concerned they might have cancer. And an MSU, and the reason I put this down is because just flagging again normal tests. In some of the large significant event analysis studies that have been done, one of the recurrent themes has been normal test results. And one of the recurrent ones was a normal MSU. So somebody comes in with hematuria, we send off an MSU to rule out an infection as we're meant to do before we do a referral, but then it's not been safety netted. So the result comes in, it's filed as normal, and the patient doesn't get followed up. So just be aware that with some of these direct access tests, even some of the simple ones like a urine test, be really, really very conscious of the ones we need to proactively follow up ourselves and safety net ourselves. Just a bit of a shout out for safety netting. All direct access diagnostics are the requester's responsibility, so we should safety net them all. Don't be reassured by normal results. Maybe make sure we're reminding ourselves why we requested that particular test. Be clear, especially if we're going away or we're not in, we're part-time, flag in the notes when we want further action needed, even if tests are normal. Always discuss with patients that normal tests don't mean no cancer or don't mean no significant disease. So if they've got ongoing symptoms, we do want to encourage them and be explicit that we want them to come back to us. And ideally, we should have robust digital safety netting in our practices. I'm not going to go into those details because we had a separate webinar just last week on safety netting that is still available, and we'll make sure you've got the link to access that webinar if you weren't able to attend first time. Is that my last? Yeah, so that's my last slide. So I don't know whether we just, if there are any questions that have come in, Zara, if we take a minute or two to answer them before I hand over to Shosha.
Yep, that's fine. Bav, have we had any questions through?
I think one came in on chest X-rays, or maybe it was just a comment.
We've got two, one from Raj and one from Lily.
Okay, so I can see one says, with regards to 23% of false negative chest X-rays in patients who went on to be diagnosed with lung, what was the time frame for those normal chest X-rays? Was that normal with? So no, this is people who'd had a chest X-ray in their route to cancer diagnosis. So it was a recent chest X-ray, and because chest X-rays are very low dose radiation, we would generally, you would say, never rely on a chest X-ray, probably beyond 3 months before, certainly not beyond 6 months. If you are suspicious of cancer, unless it's a very recent chest X-ray, and sure, you might want to comment on that at some point, but I would say certainly unless it's within 3 to 6 months, repeat that chest X-ray. And then we've got another one from Raj saying, our nurse practitioners that have done radiation training are having chest X-ray requests bounce back. So Raj, I guess my ask there would be, when that's happening, we need to target that issue by the provider that's bouncing those requests back. So either go via your quality alert in your CCG, go directly to your cancer lead or your Macmillan GP within your CCG, and then they can come directly to us at the Alliance as well, and we can address that issue, absolutely. And he says, we also cannot 2-week rule for endoscopy, iron deficiency in men or women without a positive FIT. So this may not change. So the question is, when will this change? There's a lot of new studies coming out about FIT, Raj, and so this may not change in that if the new studies come out that a positive FIT with a normal HB is as sensitive as a lower GI endoscopy, this may not change. But at the moment, that pathway isn't changing. But we will try and keep you updated with regular comms about that particular pathway. Imran says, should ex-smokers with COPD have regular chest x-rays? So I would say there isn't currently any evidence for regular chest x-rays. We have the lung health checks are just coming into Southeast London, or will be coming into Southeast London after this current lockdown period, which is for people with a high risk of cancer because of age and smoking history. You have a lung health test which involves spirometry, and then they will get a low dose CT if they meet certain criteria. I don't think there's any evidence of regular chest x-rays, but I would just say a very low threshold for chest x-rays, Imran. So any change in spirometry, any change in cough, any exacerbation of symptoms, as well as trying to optimize the treatment, that might be the right time to repeat that chest x-ray. There was something else, but it seems to have disappeared, so maybe it's been answered. Okay, great. So that's great. Any more questions that come on as Shosha's presenting, please do just put them in the chat and we'll get them to the end of Shosha's presentation. So I'm going to hand over to Dr. Dolly now to talk to us about the rapid diagnostic.
Okay, hi everyone. Sorry, you didn't make slides? Yeah, so I'm Saoirse Dolly. I'm a medical oncologist, but also one of the rapid diagnostic consultants at Guy's. So I was just going to give you a little overview of the background of RDCs for those that aren't so kind of aware of them. It was just mainly due to the kind of poor cancer, 5-year cancer outcomes in the UK, which cancer patients seem to do much worse than comparable Western countries. And there's, multi-factors in there, but part of that is concern about diagnostic delays. So when you look at the kind of 2-week rule pathway, all based around the red flag symptoms, only 5 to 10% of cancers are diagnosed through the 2-week rule pathway. Like a quarter are diagnosed through emergency, a quarter through routine outpatient appointments. And up to half of patients never get a red flag symptom. So I think that was really showing a need for this kind of pathway for patients with non-specific symptoms. So things like weight loss, fatigue, that they could be triaged through quickly. This cohort of patients generally does badly. They're diagnosed late, compared to those with the red flag symptoms, and they have worse outcomes. So the initial study was done in Denmark, who have a similar kind of healthcare system to us. And they did a study, but they had upfront radiology in that, and then you got referred to this rapid diagnostic clinic, and they had about 16% cancer detection rate. And then there was the CRUK Macmillan ACE program run across the UK across 5 different sites. And at the same time, the Guy's RDC was running. So we're pretty similar to ACE, except ours is, some of the ACE project tried different styles. Some were straight to test, some were more kind of clinically based, whereas ours is more kind of upfront, holistic, kind of general assessment, and then triage tests from there. And we've got a 7% cancer detection rate. And about a third of the patients have serious non-cancer conditions. So by that, I mean someone that we refer on to another hospital specialist. And it's this kind of model that's been rolled out nationally with NHS England. So there should be 1 rapid diagnostic clinic at least per alliance over the next year. So if you just go on to the next slide, just to show you a little bit about the pathway. So it's just to say, so at the beginning, at the top, when you see a patient, as Anthony said, just having that thought of, could this be cancer in your mind, doing the triage test, particularly the chest x-ray, the CA125, the ultrasound, so that if they do fulfill a tumor-specific pathway, you refer to them. But if it's vague symptoms, doesn't fulfill a criteria, and we all appreciate how complicated the criteria are. If you're 59 with a bit of iron deficiency anemia, you're less likely to have colon cancer than being 60. So if they don't fulfill a pathway, or they fulfill multiple pathways, then you refer to the RDC. And then we do a comprehensive upfront assessment. We try to do what we call prehab along the way. So in that 2 to 3 week period of them going through their investigations that try to optimize their diet, their comorbidities, their polypharmacy. We'll often get in touch with you to help us with that. And then we do personalized diagnostics, usually within 1 to 2 weeks. If they're lower risk and we're doing maybe an ultrasound rather than a CT, then that may be up to 3 weeks. And then we try and communicate the results to patients quickly and get a copy out to you as quick as we can. If you just go down one more, and then the outcomes are, if we find a cancer, then we have to upgrade to that tumor-specific pathway, which is really why the importance. If someone looks like they've got lung cancer, they should go direct, because we'll probably add 2 to 3 weeks onto the diagnostic interval there. If it's a serious condition, we'll refer on and ask you to follow up the outcomes. And if we don't find anything too serious, then we will discharge back with a kind of a plan. So next slide. So this is our criteria. It's all on our website, which I'll show at the end, but it's things like any adult patient. I guess the thing is you've got a concern for cancer, fatigue, weight loss, non-specific symptoms, abdominal pain or breathlessness that aren't explained by, their heart failure or other things. And then your persistently abnormal tests, your anemia, raised inflammatory markers, particularly the thrombocytosis. And I think we take it really important if you put on the form like significant concern, because that helps us triage the patient. So next slide. And then the triage test, so far we haven't mandated that these are all necessary, but it's beginning to look like we need to do that just to help us triage the pathway. But just these are kind of triage tests, but like recent, within at least within 3 months, but having a recent use need, so if we want to send them to CT, we can do that. A CA-125 or PSA, depending on their gender, and a myeloma screen. If you can, I know that's not always easy in primary care. Definitely a chest x-ray, because we pick up quite a lot of lung cancers that could have gone direct to the lung pathway. Abdominal ultrasound if there is pain or distension, but if it's going to take you 3 weeks, then you just write that on the form. And obviously a fit test, because that helps triage into the GI pathway. And now, due to COVID, we're doing an upfront virtual triage. So we're kind of trying to use that information with the history that you've given just to triage the patients. And so we can triage them straight to test. If you're really highly suspicious, they've got lots of abnormalities on their blood and we're pretty sure they've got a cancer, we can send them straight to CT and then see them with the results. And that's minimizing hospital visits as well. Or we triage them face-to-face, where we can kind of assess them fully and then decide what radiology you want to do. So next slide. So I've just got like 3 case studies. I'll try and be quick, just to kind of highlight what we do and how we might be helpful, I guess. This is a 56-year-old male that had kind of presented to the GP with a feeling of heat around his chest, long-standing kind of osteoarthritis. He was a guitar player. He'd had an X-ray. He'd had some degenerative changes, and pretty much no other red flag symptoms, no weight loss, no fatigue. But he was a current smoker. The triage test, like slightly elevated white count, PSA normal chest x-ray. So he's seen in the clinic, recommended smoking cessation, gave some dietary advice and referred to the pain team whilst we were doing the investigation. And so the CT came back with a kind of 3 centimetre pancreatic lesion, initially reported to be query pancreatic cancer or neuroendocrine tumour. The CA-99 kind of marginally up, and the chromogranins were normal. Now, I did those because I'm a HPB oncologist, but I wouldn't expect anyone else to do them. So it had an EUS, and it found to be adenocarcinoma, and then he went on to have a staging PET, and he had lytic lesions in P3 and P4. So he then went on to have palliative thoracic spine radiotherapy, a bisphosphonate, and started first-line palliative chemo. And that was all done pretty quickly within 2 weeks. Then this case study is quite interesting. I think it shows the importance of kind of clinical kind of assessment. So the 42-year-old lady that presented to the GP with vomiting, and this is right in the height of COVID. So I think initially it was a telephone consult. She was worried she was pregnant and so on. Anyway, she was brought into the surgery. The GP examined her and she had a large right upper quadrant mass. Did have a history of fibroids, a previous kind of thickened endometrium, previous breast lumps, but all been investigated in the past with no clear kind of concern. On a triage test, a bit anemic, but nothing too kind of off the scale. Albumin was down a bit, CRP. The GP had done an ultrasound which had shown extensive liver metastases and ascites. So we triaged her straight to test. And then I saw her the next day with the results, and you can see in the scan there she had almost like a fungating mass lesion in the breast, multiple liver lesions, lung lesions, peritoneal disease, and ascites. But we were able to, having seen it, this was mid-COVID, so obviously this was when you were able to do things a bit easier. We were able to get her linked in with acute oncology. We started analgesia, started her antiemetics. We got her down to breast clinic that day. They biopsied her. We linked her in with a breast CNS. So on day 3, we had the diagnosis of a HER2 positive breast cancer. And she went on to have systemic treatment, but sadly died about 3 weeks later. It just shows how acutely unwell these patients are. And then the last case study was a 50-year-old man referred in with kind of quite a good amount of weight loss, 10 kilograms of weight loss, non-specific pains in his abdomen, his chest, bit anemic, raised ferritin, no past medical history, triage tests worked. There wasn't, his ferritin was up a little, inflammatory, it looked like there was a bit of inflammation, but otherwise nothing clear. Normal chest x-ray again, as is the recurring theme, and then was triage direct to CT. And on the CT, there was a pancreatic lesion, appendiceal lesion, there's widespread edema within the bowel. If you just go on to the next slide, I think there was a pleural effusion, some ascites, some thoracic lymph nodes. So me being an oncologist, I was convinced this was a pancreatic cancer. We got analgesia, dietitian involved. We referred to the hot paracentesis clinic, and he was referred for EUS. Tumor markers then came back as normal. And I think this highlights the complexity of a lot of these cancer patients. They can go through multiple MDMs and they review them in a very specific way. So he went through the HPV MDM, he thought it was a probable appendiceal cancer. Then he'd had a couple of pleural taps, they were all negative for cytology. He had an EUS for his pancreas, and that was necrotic, no malignant cells. Then he went on to colorectal MDT, and they thought it might be inflammatory, not malignant. So goes on to have an EBUS, and he's got caseating granulomas, and it's disseminated TB. So he started treatment, the next day, but that took us about 3 weeks to get to. But it does show the complexity of these patients. So I think that's my last slide. So I think we've shown the need for the RDC to help with these complex patients with non-specific symptoms. We can help with the kind of CT on a day. So if you want to just get someone up once and seen and kind of sorted and hope that we can help with that. The use of the triage tests are really important to us to help streamline the pathway and get people seen quickly or straight to test. And as I said, if you're really worried, put that on the form, because that really, sings out to us. And then, we're just trying to get this holistic approach and moving people through. So we also refer them as soon as they've got a cancer diagnosis through the Gold Clinics, the Geriatric Oncology Liaison Service, so that we can try and optimize them so that when they get to the oncologist, that they're in a position to receive treatment. I'll put the website there and our email. So happy for anyone to get in touch, and we're always welcoming feedback from you guys on anything that might be helpful or useful with the service, or things that we could do to improve.
Thanks, Sasha.
Thanks. A couple of questions from me, Saoirse, actually, before we go on to some of the questions I'm thinking of. Okay. Firstly, if people are wondering how they refer, it's on ERS under 2-week rule as vague symptoms now, is that right?
Yes. And it's now on the NG12 as a non-specific symptom pathway. So it has been recognised as a kind of NG12 pathway.
And after referral, I know it might vary because of how capacity fluctuates, but somebody's asking how soon after referral they should let a patient know to expect to hear from you?
Yeah, so we're quite a small team, so we can get backlogged, which is why the triage test is quite important, that we can prioritise the high-risk patients through. So pre-COVID, we were seeing patients median within 7 days. We have problems with clinic capacity, but now we've kind of got more clinics running. We're hiring more people, so it should be, ideally would be within 7 days, but it is an outpatient service. So if someone's unwell, it may take us 3 weeks to see them. So it's just, unless you really highlight them as being urgent, so we put them to the front of the pile, then you need to get back in touch with us and let us know you're concerned. Or if they're acutely unwell, it may be better to present in other ways.
Thanks, Saoirse. Really fantastic service we've got in South East London. I you know, as good as anywhere in the country, this RRDC, so that is just really fantastic. Just a couple of clarifications from your slides. On the first slide, Shosha, did you say, could you mind going back to the first slide, Zara? Sorry. And while we're going back to that, Shosha, one of my other questions was, when we first created the clinic, the referral criteria was if a GP had any concern about a serious underlying condition, but I noticed that it says cancer now. Is that a conscious change?
No, it's not actually. I mean, we are happy to see patients with, you know, there's a concern, but I think we're worried that we don't want to replace general medicine and other services. But I think if you're struggling with a patient that is with serious concern, then yeah, we would still, you know, we're happy to see.
And then your second bullet point though, Shosha, says 5 to 10% of new cancers diagnosed through the 2-week referral. I don't think that's true, is it?
It doesn't include breast. I think it underestimates breast.
My understanding is that 5 to 10% of 2-week referrals turn out to be cancer, but I think there's 40 to 50% of new cancers that are diagnosed via the urgent suspected cancer referral route.
Yeah, I think, yeah.
Zara, I don't know whether you know. I think that's the conversion rate, not the detection rate.
Right. It's 25% through outpatients, 25% through A&E. It must be
50% through 2-week rule.
Yeah.
So just that's a conversion, whereas it's that the 5 to 10% is a conversion rate, where what you described is what we're actually describing is the detection rate. So we just need to change that.
Yeah.
Sorry, Zara, over to you on questions now.
Right, okay, let me just.
Well, I can see actually if you want me to take it, Zara. So it says, from Lily, it says, in the first case, Shosha, was it clear from the referral as to what had made the GP concerned enough to refer? Do you want to go to the first case, Zara?
Yeah. So
no, I think it was just that it was, I can't remember, I think it was the ongoing pain and the vagueness of it, but also that he was quite a kind of stoic guy, and that there was just, I just think it was a gut feeling. But, you know, because if you look at that, I think that's the thing that worries all of us. You can look at any patient with cancer or non-cancer and you look at their bloods, and it's just really hard to pick these things out. So, you know, I think if you've got that gut feeling, and we're trying to pick things up early, you know, just refer and we can do what we can do. Absolutely.
And I think the gut feeling, we know for any cancer, the gut feeling is the biggest, you know, it's got the highest positive predictive value for diagnosing cancer. It's just, it can be hard when you've got a strong gut feeling, but you don't know which pathway to refer them on. And that's where the RDC comes in perfectly. And I know that some of the other RDCs around the country, Saoirse, one of the referral criteria is, one is not having an obvious 2-week rule referral pathway, but the other is having multiple apparent 2-week rule pathways. So rather than trying to do 2 or 3 2-week rule referrals, which would be a bit of a disaster strategically for them to organize, if you've got multiple, you know, certainly if people are using a decision support tool like the Q Cancer or See the Signs or whatever, and they use it and it actually says do 3 different referrals, obviously that's not practical. And so that, again, that's an ideal one for the RDC.
And we're happy to see them, scan them, and then just put them onto the next pathway quickly.
Great. Thank you, Saoirse. I thought we'd have lots more queries and questions. Is there any more, Zara? I can't see any in the chat or the QA.
No, there's no more. I was just going to highlight the fact of, Saoirse, what you were saying around making sure that the information on the referral form is as much information as possible. So there is that additional clinical concerns box and that free text box. And I think that's, that is the sole purpose of that box, is to make sure that the referral has got all of the information you want secondary care to see, so that when the team at the RDC are going through the referrals, if you are extremely worried about this patient, then they're aware. So that's what I wanted just to flag.
And what's quite useful is, like, obviously we can see stuff done at Tommy's and King's and Pro, but we can't see any of Lewisham's. We're working on it to see if we can get access. So it's just attaching those reports so that we can action it quickly. Like I had one last week, a young guy, and it says bone infiltration on the scan, so I'm pretty sure it's metastatic cancer, but I could have ordered a CT last Wednesday, but I'm still waiting for the scan report to come through. So it's just little things like that, you know, we're just trying to shave off a week at a time, because we showed in COVID, we got our time to cancer tissue diagnosis down to 15 days. And there's a lot of reasons around that. We've seen people quickly, obviously people weren't coming in unless they were really, really worried. We had IR slots. There was a lot of factors to that, but it does show to me, even shaving a week off can really move you down the pathway and move things along and get them to the cancer team quickly.
And I think with the move to certainly 100% triage in your clinic, Shosha, but I think for all the suspected cancer referral routes, I mean, we should always be putting robust free text in there, but the more information we can now give secondary care, just the better they're going to be able to triage that person, both from a timeline point of view, but also to the right first test point of view. So I think more than ever, we have that responsibility in primary care to put as much information in there, making sure that all those appropriate tests are done, and that the results are pulled in, or that we've added the results if they're not pulled in. We can't rely on secondary care being able to see it on the local care record, because it's not always the case. So if we have those results, we need to be making sure that they're included in that referral.
And also as part of that, like a lot of the 2-week rule stuff's been done by consultant triage. So actually you can wait a little bit before it gets triaged. So you might lose a week, and then if it's on the wrong pathway, and then, that's my worry, is just flagging it earlier. Someone you're worried about, just flag it up, because then we can just put them straight in.
Another question from Lily. Is there a pro forma for the RDC referrals? We've been doing letters for RDC.
Oh, there's just, there's like a ERS letter where you tick, it's got the referral criteria and you can just tick the boxes, and then we don't want a huge amount of information, but just so that we're clear on, what it is. And then we can look through, we often get pulled out your consultation. So you can get a lot of the history there, but the key bits of what you're worried about, put in the beginning bit.
I think the forms are in DXS though, aren't they, Zara?
Yeah, they are.
So really we should be, ideally use the form, just because then you can make sure you are putting all the appropriate results, etc. in there. But I guess if you put it on ERS,
like ultrasound or whatever on it, and some of the triage tests.
Okay, and there's no more questions coming in the chat. So one final ask, if anyone wants to ask any other questions, but if not, then we will sign off.
Yeah, and I guess for me, really just use the clinic. It's fantastic. Use all our direct access diagnostics if we can. And if you're running into problems with direct access diagnostics, please flag it. I know it's frustrating, but unless it's flagged and we can target, either the CCG or ourselves at the Alliance can target why things are happening that way, things don't improve. So don't just get frustrated and then take an action and contact the right person so that it can be remedied.
Thank you. So just an ask of the attendees, please complete the evaluation form. You'll then receive a certificate of attendance, and the link will be on at the end of Zoom when we finish, and a link will also be sent out to you all. This will be uploaded, so the webinar will be uploaded onto our YouTube channel, and a link will be sent out to all attendees. So please share that with your colleagues in your PCNs who may not have been able to make it, and the slides will also be available afterwards. So, we've got...
No, it's just a thank you, Zara.
Oh, okay. Thank you so much, both of you. Your presentations were great, and hopefully everyone's enjoyed themselves, and looking forward to seeing you all at the next webinar. So take care, everyone. Have a nice afternoon.